All right. Okay. So I'm going to give you a high-level overview. We're going to talk about healthcare and some of the critical issues that we're facing in long-term care specifically. So I wouldn't be a teacher if I didn't give you an overview. So I'll give you a bit of context, because I think this is a diverse room, and a lot of you may not be familiar with healthcare in terms of how things go. So the projects I'm going to talk about, actually, Brenda is part of it. We call it the Healers Project. So I'm going to give you a bit of an overview of that, our methods, our approach, and some of the key findings. And if time permits, I might give you the takeaways. But this project, like Nina's, is also ongoing. So I'm going to only share with you the first half of it. All right. So those of you who are in healthcare know that we are facing immense pressure, and that is impacting the workers as well. And so some of the issues that came up post-COVID was already in existence before COVID, but of course, COVID, as in many industries, did amplify the issue. And so right now we find ourselves with immense shortages, but that was there way before COVID. And so what's happening now is that we are talking more about it and how it impacts quality of patient care, and in my case, resident care, because we're talking about long-term care. And then also, of course, the mental health and well-being of nurses and other healthcare providers. I mentioned nurses because I'm a nurse, but it's affecting all healthcare workers. And so the ministers are now talking about, we have to reinvest in this sector. But we already know that this is the time for us to really make an impact. Otherwise, I'm afraid 20 years from now, somebody's going to be standing at the same podium talking about staffing shortages, and we're not making any improvements. So I wanted to show you this graph. I hope you can see from the back. We know that we have an aging population. I don't think that's a surprise to any of us in this room. But what is interesting is that by 2037, we're going to have older adults, 65 plus, will grow up to 68% of our population. And that is significant. And so we know that the healthcare needs is going to be immense, and workers will be needed to support them. So if you take a look at this graph, you'll see that 1998 to 2024, that we've doubled the number of workers in the system. However, in terms of the growth, has not been consistent to reflect the aging population. So with that, we have more people, and some politicians will say, yeah, we're hiring more staff in healthcare, but the outcome is almost the same or even worse, right? Because people are more complex, they're living longer, and they have more needs. So I wanted to show you, this is from 2015 to 2022. All industries suffered because of COVID, and even before that, right? So double in all industries, but healthcare specifically is triple. But the subsector of healthcare, which is long-term care, is 3.5, which tells us that there's even greater need in this particular sector. Back in 2021, Health Canada did a study to see how all healthcare workers, how are they experiencing stress? And they found that between about 80 to 95 reported significant stress, high stress. They also tested burnout, and they used burnout inventory, and 60% said they were at the severe, right? But some will argue that that was that was in the height of the pandemic, so everybody was stressed out. But I will argue that perhaps we haven't had any significant drops since then. People are still reporting distress, they're still working short, and it's almost like in some sectors, it's almost like, oh, well, the lockdown is over, so, we're good, right? But there are people who are still living with COVID, and the needs are still there. So our team wanted to take a look at how we can bring awareness to the mental health of healthcare workers and think of ways that we can intervene. But we wanted to do something a little bit different, because typically we are very prescriptive. We tell people what they need. And so with this study, we wanted to hear from their perspective what they need and perhaps help us create some solutions going forward. So we wanted to really find what would be a good intervention, because we keep talking around the circles about the same issues over and over. When I was in school, my professor was telling me about there's critical shortages in long-term care, hospitals and long-term care and communities, etc. And now I find myself standing there saying the same thing to my students. So we wanted to hear from healthcare workers and their experience. And we want particularly, at least for me, I want to know what we can do at the systems level, because I'm often a little bit disheartened when the strategies or the issues are, oh, well, you know, from an individual perspective, maybe you need to learn how to deep breathe and cough, or maybe you need to know how to do yoga and take a time off for a day or two. But we know this is a systems problem. Our system is broken and we need to really look at it seriously. So that's what we wanted to do, and hopefully our end goal was to help with the turnover and help with retention. Okay, so we utilize a co-design method, and we are doing a mixed methods, multi-phase approach. It took us over a year, as you can see on the slide, from July to October, to be able to get people together, especially with co-design, where you have to keep going and asking these people who are already maxed out. And we keep asking them, can you meet with us for 2 hours on a Zoom call, if you can, and talk about what's going on? And it was quite traumatizing, too, for people to have to relive some of the distress that they encountered. But they were really more than willing, actually. In fact, some of them said that it was therapeutic, because they heard from others as well going through the same thing, so that they didn't feel alone. So we felt a little bit good about that, but we had to talk about the ethics of doing research like that and triggering people to relive their injuries again. So, but it was pretty good what we ended up finding. So of course, recruitment, as you all know, is very difficult. I think that's the most challenging part of research. But we managed to get personal support workers, who made up majority of the participants, which was quite exciting, because typically their voices are not included in research. It's usually, you know, the people in power, right? And so it was really beautiful to get them to come at the table to give us our perspective. We also had more social workers than we thought, but then it makes sense because it was during COVID, they're dealing with distress. But from my line of work, I typically don't hear from social workers. I'm only working with nurses and medicine, and that's pretty much it, right? So it was really lovely to hear their perspective as well. We couldn't get the OTs though, so I don't know. But then in long-term care, we don't have a lot of OTs, so there we go. Actually, I'll tell you later, one of the papers that we ended up publishing from this work, they said, well, you know, you have one behavioral therapist, so you should remove them. And I said, well, who's going to hear their voice if we keep deleting the people who are now maxed in the system? So that's our recruitment. Like I said, it was a co-design, so we kept coming back. We did it. It was very iterative in terms of the process. When we got what we think we obtained from the recordings, we went back. So we kept really making sure that the findings were authentic to the participants. There was their voice and not ours taking over. So when we ended up getting to their final approval of the key findings, and we summarized it into 5 main points. So I have it over here. And some of it wasn't surprising, but it was important to highlight these issues that they raised. So for example, mental health and psychological distress, they talked a lot about even feeling guilty taking mental health day if they needed it. And it's in a way sort of similar to what you're talking about. It's kind of hard to grieve alone because you are always on the spotlight. Somebody's watching you. So they talked about the need to really address that in a meaningful way and not just one time off, just really instilling some kind of programs that are long lasting. Of course, workload and planning, that one wasn't surprising. Everyone in healthcare is overworked, and everyone around the world, I would argue, that is overworked as well. So they talked about that and how they're really taking care of patient load that's quite unsafe. Some of them had like some significant number that I couldn't even imagine how they were able to do their job. They talked about regulatory and bureaucratic burdens, and that was in reference to documentation, because they felt like the ministry wasn't working with them. So when they come to the long-term care home, it's almost like a police. They're looking for problems and not what's working. They also talked about leadership, and we know how significant leadership is in the work environment. But what was even more, to me, is fascinating was the recognition of sector image. They felt like everything you ever hear on the news about long-term care is negative. They never highlight any of the positive things that are happening. It's always, a resident fell, or just always negative. So they talked about being very mindful of the good work that's happening that needs to be showcased. Yes, bad things are happening, but this is not all negative. So with time, I'm gonna only highlight 2 quotes for you. One of them from a manager, and they said, "It is very much like you drowning, and I know the frontline feel that way too." What they were talking about was that even from a management perspective, their voices are often not heard, because typically every problem you say, well, the manager, what's the leadership doing about it? But they forget that the middle manager or the middle leader is also encountering their own struggles, and so they need an outlet. So they were really, that was eye-opening for me, because a lot of my critique in my earlier work has been, what is the leadership doing, right? But leadership also needs support. Another quote from a nurse says, "It's frustrating that no one talks about how we feel, how we bring people back to life. They just focus on the failures," which is to what I said before. It's always what's not working, and not the fact that people are working around the clock trying to make these older adults' life a lot better in many regards. So in terms of implications, this is only phase 1 of a 3-phase study. But we felt like we have some things to share. And, this is not, I guess, overly surprising, but I think we do need strategic workforce planning. We need to really invest in a way that's meaningful, and not just talking around the circles and saying, oh yeah, something needs to be done, but nothing really is being done. So we have to think about how we reinvest in the system, because certainly we know that burnout impacts quality of patient care and also the provider's care. So we're going to constantly be short, people are going to be in distress, and nothing is going to change. We also think that it's important in terms of systems reform to talk about mental health programs, really, and not having the stigma, because some of them talked about there's a stigma even when you're accessing these services. And so how do we do it in a way that it's welcoming and understanding that we all have mental health and we all need to take care of it. I would just focus on also the resource allocation is one of our implications. I think it's important that we don't ask people who are already overburdened to repeat documentation. I don't know how many of you are familiar with healthcare, but I remember my days in emergency, I can ask the same person question like 100 times and I'm writing about the same thing. So how do we do it in an efficient way so that the workers are not overburdened and being asked to do the same thing over and over? It's actually it's not efficient, and it doesn't align with our goals from the nationwide perspective anyways. And then of course, investing in leadership and also supporting the middle manager. I think it's a role that most people don't want, but they find themselves in it because they've been, let's say, for example, you've been a nurse for a long time. Oh, good. You would be a good, leader on this unit, but without any formal leadership training or support thereafter. And then the last piece that I will probably touch on in my next slide is about co-designing with staff. It's really important that we hear from those who are most affected and not being so prescriptive and dismissive of their voices. They also talk about tokenism. They didn't want to feel like they're being asked for their perspective, but they don't see that being translated in real life. So some things to take away. Certainly we need to think of, again, like I said before, a very strategic workforce planning. It's really important. And collecting data. We know that we don't really have a lot of data, especially if you think of people from equity, deserving groups, indigenous population. We don't really know that workforce, what that looks like. And we know the implications of that, because if you don't collect the right data, how are you going to really intervene appropriately? And then also addressing quadruple aim is important, which is the provider's experience. Oftentimes that's not. Yes, we are here to care for patients, but it's important to know how the provider is doing, because if the provider is not doing well, they cannot provide good care. It's just as simple as that. And then I will skip to my last point about research. So there's one thing that I noticed, there was this thing about what are you going to do with the findings? What is going to happen? I think we are at the point where we know enough, and now it's time for us to intervene. So we have to move beyond just collecting the data and actually intervening. And that's one of our next phase of this work, is actually getting what will work, consult with a long-term care home, and actually implement some of these and see if it's effective and evaluate going forward. So we managed to get this work out, and the QR code does work, but this is more of our process paper, talking about how we're going to lay this out in the 3 phases that we're beginning. I think it's really important for us to sort of lay it all out and get a sense of, is this going to work? Is this not going to work? And how do we make it better in going forward? Because if our work end up just doing the same thing and nothing new, then we are also part of the problem and not the solution. So that brings me to the end. Thank you very much. And you can also scan the code if you want to know more of what we're doing, and we welcome different perspectives. So if you're interested in joining us, Brenda and I will be happy to have you. Thank you.
Thanks a lot.
Yeah.